Welcome to the second New England Journal of Medicine special podcast on avian influenza. I'm Stephen Morrissey, managing editor of the journal, and I'm talking with Eric Rubin, editor-in-chief, and Lindsay Baden, deputy editor. Today we're joined by two guests. Hilary Marston is the chief medical officer at the FDA. In this position, she helps coordinate efforts across the agency. She has a substantial background in pandemic preparedness and held several leadership positions at the White House and the U.S. National Security Council. Dimitri Daskalakis is the director of the National Center for Immunization and Respiratory Diseases, which is responsible for preparing for and responding to diseases, including both new and ongoing outbreaks. He also spent time recently at the White House, where he was deputy coordinator of the response to Mpox. Eric, let's start with you.
Thanks, Steve. As I said in our prior avian flu podcast, we want to make it clear that the virus that's currently circulating in cattle in the U.S. isn't causing a major human outbreak, and we hope it never will. In fact, there's only been one patient that's been reported to be infected, and that patient had only mild illness. However, if there isn't an outbreak this time, we are worried about what the next pandemic flu will be. And so this is a great opportunity to think about how we'll deal with it. Today, we've got some perfect guests to specifically talk about preparedness, what's going on now, and what needs to happen.
So, as you say, Eric, right now we know there's a multi-state outbreak of influenza in cattle. How are we tracking that? Do the cattle get sick?
So I can take that one. The answer is yes and no. So in terms of does the cow get sick? And then I'll talk deeper into how we're tracking it. The majority of cases among cattle really have been identified when a very specific syndrome is seen. And so this is a combination of decreased feeding, and this is dairy cows, and then decreased milk production. So there is also a reference to the milk becoming thick and colostrum-like, and those tend to be the signs that something is going on. So that tends to prompt testing. Additionally, we have heard from our USDA colleagues and our connection through our One Health, which is our veterinary and human health component of CDC and other agencies in the US government, that there are episodes or instances of cattle that are asymptomatic who have also had this detection. So a couple of really important things that USDA is doing to increase testing includes an order that came out a couple of weeks ago that really directed cattle farmers and dairy farmers to test any cattle that move. And so this is likely going to result in additional testing and most likely identify more cattle that potentially are asymptomatic. So that's a component of how it's being sort of followed sort of on the cattle side. Additionally, I think, and I think Dr. Marston can talk in more detail, a lot of effort has happened to sort of test the milk supply specifically, sort of to evaluate pasteurization. So I'll leave that to her. But I'll also add that we're doing a lot of work to evaluate sort of the H5 situation and how it sort of interacts with humans. So I think it's a combination of some industrial strength surveillance that we're doing, and it's our standard seasonal surveillance that we do for influenza. So I think one of the things that I'll say over and over again is that our seasonal preparedness is what makes us prepared for these novel or urgent events. But so the work that we're doing to follow what's happening in emergency departments, what's happening in both public health and commercial lab testing, all of those aren't showing any signals of increase of human influenza activity. That's coupled with shoe leather epidemiology. We're working with the states who are monitoring now over 260 people who have had exposures to cattle with HPAI or H5N1. And that has resulted in about 33 people who are symptomatic ultimately getting tested. Along with that, We're also doing things that are more exploratory. And I think we're looking at how we can use wastewater specifically for influenza A to really learn more about just the general situation, maybe not necessarily leading us to a human, but potentially also leading us to other reservoirs, whether it's animal or animal products that could also be detected through wastewater. It's a developmental area, but one that I think we're going to be sharing more information about in the near future.
Hillary, did you want to add anything to that?
Sure. So I can come in a little bit on the milk supply and what FDA has been doing around this. So this epidemic has been a lesson in One Health. It's also been a lesson in how large that the FDA is, because obviously we engage on medical countermeasures, vaccines, diagnostics, therapeutics, but we also have the Center for Veterinary Medicine and we have the Center for Food Safety and Nutrition. So many areas of the FDA are engaged here. For milk safety, we continue to believe that pasteurization is working for the milk supply, keeping it safe. We continue, along with our CDC partners, to advise against drinking raw milk. Glad to talk about that more if you'd like. What we've done in order to reinforce our position around the pasteurization is we've done a nationwide sample, and we're continuing to fill that out of retail milk. So just pulling things off the shelf, right? We tested those for PCR, and about 1 in 5 were positive by PCR. So viral fragments, not necessarily viable virus. So that was then tested for viable virus, and actually none of those were positive. So we didn't see any viable virus on any of those samples. That's certainly reassuring. What we're following that up with now is further testing about pasteurization parameters. So what are the optimal time temperature combinations to pasteurize milk?
Hillary, if I can follow up on that, a lot of good reasons not to drink raw milk here in the collection of infectious disease doctors. But do we know what kind of risk there is? Certainly, if there would be viable virus, is transmission efficient through drinking milk?
It's such a good question, and one that our colleagues over at NIAID and also at USDA are looking into in more detail. So this is a novel situation, right? Influenza has been seen in cows, but rarely in the past. For example, there was an outbreak in the UK back in the 90s. But the actual likelihood, the actual infectious dose of getting milk from raw milk, getting influenza from raw milk is not known. So we need to do animal studies. We need to understand in different animal models, mice, ferret, et cetera, what that sort of infection model would look like. But it's to be determined. That being said, as you rightly pointed out, there are many reasons not to drink raw milk. And this is just another one.
And as we think about the food supply, obviously raw cheeses or other food supply considerations we should be thinking about or being monitored to ensure safety?
So we are looking at different types of dairy products. Thankfully, a lot of dairy products are actually made from pasteurized milk. Obviously, read your labels. But the first studies that we did are reassuring on that front. We've also looked at powdered infant formulas, something that I know is of interest to many folks, and those looked good as well.
And sorry, just one more question about that. How about beef cattle? Have there been cases?
Oh, that's a good question. So our USDA colleagues are looking at that. They've been doing some meat sampling. I think Dimitri probably has more detail on it.
So yeah, I think they have been looking at meat sampling, and I don't know what's sort of publicly available yet, but I think so far everything has been fairly reassuring. And so we'll leave it to our USDA colleagues to go into more detail on that. But again, I think no signal that I've heard of meat at the moment. But again, not sure how much of the detail is available yet.
As we think about the food supply, as Eric pointed out, there's been one case to date that we're aware of. So even though, Hillary, as you mentioned, we can find nucleic acid fragments in different parts of the food supply, there's no evidence of transmission that way at this time, correct?
That's correct. Dimitri, do you want to come in on the surveillance that we've been doing?
Yeah. So just, I think we're really sort of using layered surveillance systems that both include food safety as well as our sort of regular flu surveillance systems to sort of make sure that there's sort of no surprises. I mean, I think that the reality is we really don't know a lot about what ingestion of high dose flu could look like. I think we have some strange things to think about. Like there are, I think, instances that are seen in some parts of the world with drinking of duck blood of some of the ducks that have been exposed to flu. And we don't really have a lot to sort of go on to be able to sort of say, what does this look like? So rather than being limiting, we're looking at like our normal respiratory surveillance work. So again, that ER work that says like, are we seeing increasing flu cases? The laboratory work that we're using both from the commercial perspective as well as public health to say, are we seeing an increase in testing or an increase in test positivity for flu A? And then overlapped on that are our sort of food sort of safety and food outbreak systems that are looking for any sort of signal that there is like some other non-respiratory manifestation of this, like a GI manifestation. All of those are looking very, very, very quiet. So nothing that is sort of signaling anything of particular concern. But again, since this is like a new territory, since we don't really know the answer, as Dr. Marston said, as Hillary said, I think we're just keeping it really broad to make sure that we're looking for flu signals anywhere they may pop up.
And then what's the signal that would make you want to act? Do we have to see human-to-human transmission, or can we monitor animals for the appearance of concerning variants?
I'll start, and I'm sure Dr. Marston will have more to say, is like we're acting now. And so I think that that's probably the most important piece of this is that, I think, though we only have one human case, there is a lot of sort of resource and attention that is sort of going into this event on the human as well as the animal side, given sort of the potential that this could have both on animal health, on food safety, and even potentially on human health. So I think that, the work that we're doing to sort of do the surveillance, the lab work that we're doing in association with USDA ends up being critical in sort of understanding what's happening with the virus. And I'll go back on my favorite sort of soapbox and say, supporting public health to do seasonal influenza work, and other respiratory virus work like SARS-CoV-2 ends up being the same system that we use to be able to better evaluate the risk from novel or emergent agents. And so this is exactly that same situation where within a very short amount of time, when the one human case was identified, specimen was shipped to CDC. Very quickly, that was sequenced. And within like a blink of an eye, we put up a risk assessment about that sequence that really highlighted the fact that there were no sort of, there was one mutation that was associated with mammalian infection, but that we didn't associate as an adaptation that could result in more efficient transmission to humans. We also looked to see if the virus had any candidate vaccine viruses that we already had in the hopper that could potentially be used if we had to move to a vaccine stance. And so we identified two, and I'll let Hillary talk more about those as well, but we identified two based on the sequence and are then doing additional work, both in specimens that are stored from clinical studies, but also in animal models, like in ferrets, to really see sort of how closely this is aligned to those candidate vaccine viruses in the scenario that we do need to trigger a vaccine strategy. And then lastly, we're a vaccine program. And then lastly, we also look to see if the virus is susceptible to FDA-approved antivirals for influenza. And we do that both by genotype and phenotype. So looking to see if we have mutations associated with resistance to the approved drugs, and also then do phenotypic testing and, in effect, grow the virus against drug to see if it's susceptible. So, the trigger is that when we see an event, you in effect put into motion the seasonal influenza apparatus that makes sure that we have a flu vaccine every year, but also identify if there are any urgent or changing scenarios for either known or new influenza viruses.
Yeah, and the only thing I'll add to that is that we have been watching H5N1 as a government for some time now, and as an academic community. We, through investments from the Administration for Strategic Preparedness and Response, have these long-lasting relationships with influenza vaccine manufacturers, right? So they have started work on some of these vaccine candidates before this recent outbreak of in cows. So we're building on work that was done in advance, and the sort of preparedness that I think we'd all advocate in many other areas as well.
So on the preparedness front, which is something we're all very concerned about, Dimitri, as the CDC's primary mission is surveillance, is identifying microbial threats. As we think about this novel threat, our current influenza process, want to help me understand how it helps prepare us. This is an influenza A, H5N1. Therefore, does the influenza A diagnostics for other H and N types cross-react? Does that allow us to have a testing system that can be deployed immediately? If I'm a clinician in an area caring for a farm worker who may have symptoms, how do I go about doing the diagnostic workup, and are things even available to me?
Great. So first I'll start with the first part of the question, which is how does seasonal flu preparedness get us ready for an event such as the one that we have today? And I'll tell you that it is one of my favorite things that happened in joining NCIRD, which is the Center for Immunization and Respiratory Diseases, was my very deep dive tour into the laboratory at CDC for influenza. And so it is a very sort of interesting machine in terms of how things move. As an example, all over the US and also globally, Influenza Division has a footprint. And that footprint really is to keep specimens and sequences moving to CDC so that we can characterize viruses and identify ones that could potentially be important candidate vaccine viruses. So as Dr. Marston said, as Hillary said, the work that did that is sort of what has identified the two candidate vaccine viruses that we have living in our sort of backup here to be able to move quickly if we need to into a vaccine program. So we get virus, we sequence it, we characterize it, we do antigenic studies, we do pathophysiology studies, we do all of the things for a routine season that we do when we have something that is more emergent, such as this H5N1. As an example, in Cambodia, if there's an H5N1, we actually do the same thing with the H5N1 from Cambodia to better understand what's going on. So I feel like that system, that sort of seasonal preparedness system, really does create that sort of end-to-end and also efficient mechanism to go from something is happening in the public health universe epidemiologically into we have a very well-characterized virus that we can then move, into next phases if it ends up being more of a threat. Now, to your question about diagnostics. So, this is a flu A, and based on our assessment of the virus that was identified in cows as well as in the one human case, flu A tests will work to identify this virus. So that's really important as a step one. But for clinicians who are listening, at this point, if someone identifies a human who has respiratory symptoms, including conjunctivitis, symptoms that are concerning, with an appropriate occupational or exposure history, at this point, the best thing to do is contact local public health, because the H5 testing that needs to be done actually happens currently in our public health labs. We are currently working through what it would take to expand this and increase the circle of laboratories that are able to do it. And again, we have experience in COVID, most recently in Mpox, and are really working sort of across US government and industry to identify how we can move this through more quickly. So the answer right now is to really take a good history. And if you identify someone with the appropriate exposure, definitely call your local public health department to assist you in appropriate testing.
And that assay is FDA cleared, the CDC assay.
And that assay is FDA cleared.
That's for H5, but
Correct.
the flu A1 has been cleared a long time ago as we're using it clinically.
Yes.
So how will a decision be made to pull the trigger on actually making a vaccine? Who would be involved in that decision? And then once the decision is made, how long will it take to manufacture the vaccine at scale so it can be delivered to a large population?
So I'll start, and I think Dr. Marston will have a lot to say as well. But I think that the answer is that this is really, I think HHS is really the lead in terms of thinking about what the appropriate time is and sort of the appropriate sort of vaccine program to launch in the scenario that we have identified reasons to do that. So, frankly, a lot of these may be a little bit different. And so lots of considerations come into play. What's the severity of disease? Are we seeing human to human transmission? Are we seeing concerning changes in the virus that make it more likely or to transmit to humans? Are we seeing changes in the virus that may lead to increased illness or pathology? So all of those things are taken into consideration. It is an all of U.S. government within HHS discussion that also includes other scientific experts outside of government to really come to the point of, do we launch a vaccine program and who should be getting the vaccine? I think that sort of leads to the second part of the question, that there are like different tiers of access. So we have sort of vaccine that is available that requires additional steps. That often would take on the order of weeks. But if we were then to launch a larger population-wide event, that is something that you'd expect to take more on the order of months. I will just reflex back and make the point that seasonal preparedness is so important for pandemic or like outbreak preparedness, because the existence of candidate vaccine viruses that we have today shaves about 8 to 12 weeks off the process. So the fact that we have these and they exist, though there is still something on the order of weeks to get to a vaccine that launches in a smaller way and then months in a larger way, by doing this work, we are queue jumping ahead a bit to be able to make the process move faster. Dr. Marston, I'm not sure if you have anything to add there.
Yeah, so just some small additions. So if you guys remember back to 2009 and the H1N1 pandemic, then we were able to take an approved vaccine and do a strain change approval. So it wasn't an emergency use authorization, it was a straight strain change approval. These pathways are available still, both pathways, EUA and a straight approval. They're available because we have 3 approved H5N1 vaccines. We have Sanofi, we have Seqirus, and we have ID Bio, which is a GSK subsidiary. Depending on the data that's available, and typical regulator, it'll depend on the data. We could choose to go down either of those paths if it looks sufficient to justify it. But as Dimitri was saying, there are it's not a toggle on or off situations. There are different segments of vaccines that are available at different states of preparation. So a small amount, which could be ready in weeks, and a larger amount that's available in bulk, and then even more potentially if there were to be more manufacturing. All of that would be under the Administration for Strategic Preparedness and Response. They only have those small amount of doses because they've invested in the National Pre-Pandemic Influenza Vaccine Stockpile. So important to give credit where credit is due there. The pathway here, the other thing that I just want to emphasize is that we focus a lot on the vaccine here. It's going to be important to just pull a lesson from COVID, where prevention has to be multifactorial, right? So if we're actually in that situation, we shouldn't act as though it's vaccine or nothing, right? We have antivirals for post-exposure prophylaxis. We have better understanding of ventilation. We have PPE that's available both on the commercial market, state stockpiles, and additional strategic national stockpile. So I wouldn't want to see us take a step backward where we're only relying on one tool.
I just wanted to add one thing to Dr. Marston, which is to emphasize again how important that collaboration across HHS is, from the regulatory all the way to the implementation side, and then also the sort of, maintaining and building confidence in products. So just putting that all together, like ASPR, FDA, CDC, all of us working together, it really is, I think, what generates preparedness in this space. And I think, again, just wanted to double click on that before we're done with questions.
Hillary, what do we know about treatments for the current strain of H5N1? Are the antivirals that we have on the shelf effective against this strain?
Yeah, so far, based on the sequences that we've seen, in large part, it looks like they will be. So particularly the neuraminidase inhibitors, thinking of oseltamivir in particular, and the newer baloxavir or Xofluza. These are both available on the commercial market. We had some shortages of oseltamivir a couple of years back. We do not anymore. Multiple generics manufacturers, but also there are state stockpiles of oseltamivir and the strategic national stockpile should that be necessary.
So I want to go back to something that Dimitri and Hillary were discussing. And Hillary, if you can expand on this a little bit. The flu preparedness for every season. We have a flu outbreak every season. We have a fair amount of vaccine infrastructure. You pointed out that we may have a small amount of vaccine available in weeks and a larger amount in a month or two.
In months.
In months, and it's graded. As time goes on, more will be available depending on the need. This kind of investment in sort of the right vaccine strain, the right development of it, seems like a relatively modest investment for a significant amount of time savings. And I think Dimitri mentioned 8 to 12 weeks. Help us understand how we save so much time with this kind of planning.
Well, rather than having to do the initial lab work of making sure that you've got a strain that's established well in eggs, for example, or in cells growing well, that it looks like the immune response that it generates in the animal models will neutralize the virus well, all of that takes time. Right. So if you've done some of that work in advance, then you are further ahead. If you have ideally, in the case of the weeks doses, if you've actually gone to the step of not just having it in bulk, but having it fill finished, or at least in vials, then that is incredibly helpful and accelerates you quite far down the line. These are investment choices, right? And every department has to make those decisions, and HHS has decided, watching H5N1 for some time, that this was one that we needed to prioritize from a preparedness point of view. You said that it's a modest investment, but as we're looking across all of the pathogens out there as a U.S. government, decisions have to be made. So pandemic influenza has been a priority for some time.
So this preparedness in part is there are certain vaccine strains that are available because they've already been made. As Dimitri said, there's some cross-reactivity of what's already been made with the current circulating strain. Presumably, the current circulating strain is in the process of being adapted for a closer match in terms of the vaccine development process. That may be a few months away, but there are parallel processes in this preparedness to have as close a match as possible.
Well, I think the important thing to think about here, so we're so used to, with seasonal influenza, thinking of getting the match just right? Like we need to watch it in the southern hemisphere to make sure we've got it right for the northern hemisphere, et cetera. Here, we're not introducing a vaccine on a background of years and years and years of immunity, right? We're introducing it to an immune naive population. So the importance, the breadth that we expect is going to be broader than what we would expect from a seasonal vaccine.
We have seen H5N1 infections in humans before, just not so much in this country. What have we learned from those that will help us deal with this current, at least, cattle outbreak?
It's a good question. We've learned to be respectful of this virus, certainly. We've unfortunately seen a severe disease, particularly in Asia when it first appeared in humans. Typically with outbreak, those first couple of cases that you become aware of probably do overinflate the case fatality, right? Because you're looking at the first cases that are most obvious to clinicians. So you typically see that come down over time, and certainly I would hope to see that. But we've learned that it can cause severe lower respiratory infection. So this is one of the reasons why we prioritize it.
So one of the things that we sort of learned with COVID was the importance of being able to make a rapid diagnosis. And Dimitri mentioned strategies to diagnose this infection if clinicians are concerned. How has the agency improved processes so we can have better point of care or rapid diagnostics, which for respiratory viruses may be quite important in diagnosing and controlling? Is this something that has an expedited pathway so that we can have more point of care or easily accessible diagnostics?
Well, I think we've learned quite a bit through the COVID pandemic about flexibilities that we have as an agency and how to deploy them in a science-based way that protects public health. For influenza diagnostics, for those that are already 510(k) cleared, we could look at potentially amending if there is data that's specific to H5. We could also look at opening up additional pathways. Obviously, with COVID and Mpox, we opened up the possibility of an EUA. This is something where the companies would need to come to us with information that really justified it. So this is something that we do in collaboration with the companies and looking at the information that they've brought.
Thank you, Hillary and Dimitri, for joining us today.
Thanks so much.
Thanks again for having us on.
Thanks also to Eric and Lindsay.